Vancouver, Canada. He will be talking to us about the high-risk premenopausal luminal A breast cancer patients deriving no benefit from adjuvant chemotherapy, the results from the DBCG77B randomized trial.
Yes, thank you. Yes, I'm a clinician scientist pathologist from Vancouver. On behalf of my colleagues and my collaborators in the Danish breast cancer group, I'm pleased to present these results. Here are my disclosures. The intrinsic subtypes of breast cancer is something that we've recognized over the past decade plus by molecular tests. These are the main subgroups that are not necessarily readily identified just by looking under the microscope. And a lot of the older trials didn't think about the subtype analyses, as it hadn't been figured out at that time. There's a large body of data that's built up now, suggesting, for example, the luminal A subtype has a much better prognosis than the other subtypes, and that the different subtypes may respond differently to particular types of chemotherapy. But the level of evidence behind these predictive questions is often from in vitro studies, animal studies, cohort studies. What we've really needed is randomized clinical trials to look at these findings, particularly with a really stringent statistical analysis like an interaction test for chemotherapy versus no chemotherapy and subtype. But it's been very hard to do these studies because basically the question was settled back in the 1980s that adjuvant chemotherapy helps women with breast cancer. And since that time, it's been unethical to randomize women in most settings to no chemotherapy. Most of the studies have been different types of chemotherapy as choices. And so on these older trials, unfortunately, material wasn't saved, or in the few cases where it had been used up for other studies, and there's not enough cases available to make these distinctions. We were fortunate enough, after a lot of looking, to identify a clinical trial that did have material remaining where we could go back and address whether subtype was predictive for chemotherapy. And this is a Danish trial that actually started way back in 1977 and finished accruing patients by the mid-80s. This was a trial of over 1,000 premenopausal women, and they were high-risk women, certainly by today's standards and by standards for a group you might consider not giving chemotherapy to. And almost all of them were node positive. Otherwise, they were large tumors or invasive into the chest wall. And women were taken regardless of hormone receptor or HER2 status into this trial, and they did not receive endocrine therapy. They did, however, get what would be considered more than adequate local therapy by today's standards, mastectomy supported by axillary node dissection and chest wall radiation. And then they were randomized to 4 different arms, 2 arms receiving no chemotherapy and 2 arms receiving chemotherapy. The chemotherapy was either classic CMF, or what was tested at that time was cyclophosphamide as a single agent at a higher dose. Both of those 2 chemotherapy arms had similar results, and they showed that chemotherapy works. They were one of several trials at that time that demonstrated clear advantage of giving chemotherapy in the adjuvant setting. In this case, the hazard ratio was about 0.6, favoring chemotherapy over control arms. So this material let us address the question that we've really been wondering about. I think it can address it very well and thoroughly, is do luminal A tumors, the low-risk intrinsic subtype, derive any benefit from chemotherapy? And we could look at this with an interaction test between luminal A status and chemotherapy for the trial's primary endpoint, which was 10-year invasive disease-free survival. So for this purposes, we were able to combine the 2 chemotherapy arms and the control arm with an ineffective agent, levamisole, as a no chemotherapy arm in a formal retrospective prospective study. So that means that we had to lock down everything in advance, what the definitions of luminal A would be, how we would determine that, what the statistical plan would be, primary endpoint, much like a fully prospective clinical trial. And my team in Vancouver, we did the pathology, we did the subtype calls, but we had no access to the clinical data. That was all handled in Denmark by the central statistical office according to the pre-specified plan. So a strong study design, I would say. The material we were constrained with was tissue microarrays that had been built from the material from this clinical trial. That meant we could address this by immunohistochemistry. My group, as well as others, have published extensively on how to identify these subtypes by immunohistochemistry, and with 6 biomarkers, as we published in 2013. There is a lockdown definition of these subtypes, but for the purpose of this study, the main issue is, are you luminal A or not luminal A? So luminal A is defined as being ER positive, HER2 negative, also low proliferation rate, as measured in this situation by Ki-67 index being below 13%, And then high progesterone receptor expression, which is a marker that the whole ER pathway is active and critical to the biology of this tumor. Here's the consort diagram with the short version here is there were 709 of the original 1,100 patients available on the tissue microarrays, and we got results for 633, a little over a quarter of whom were luminal A patients. This group of women in the study set very much mirrored the original trial, and again, this is a trial of younger women with large tumors, almost all node positive, high-grade invasive ductal carcinomas. And that's a group where the chemotherapy works, and our study set certainly reflected the results of the whole trial that chemotherapy works. Where it works, however, is in the non-luminal A patients, and here is the results of more or less expected results in non-luminal A patients. The dotted line here is the patients on chemotherapy, and the solid line is off chemotherapy, and you can see a very large difference, hazard ratio of 0.5. So the key result of our study is this: the luminal A patients having completely overlapping curves, where they are, although their prognosis is better because the whole curve is higher, there is no advantage of being given chemotherapy. The hazard ratio is 1, and the formal statistical test, the interaction test, is significant. So there is a difference, and this is predictive. Main limitations of the study is that we used an immunohistochemical method, which has issues around its own analytical validity, and I'm presenting a poster P10101 today on Q67 testing, and we were using only the tissue microarrays. Currently, we're trying to get the original blocks, and isolating RNA for gene profile analysis is another way to identify the subtypes. This is an older trial, and so its direct relevance to today's population has to be discussed. For example, these women did not get anti-HER2 therapy, anthracyclines, or taxanes. They are a high-risk group, and they receive no endocrine therapy, and you might expect that this would be a particularly difficult set of patients to find a group lacking benefit from chemotherapy. Nonetheless, we did find that group. So the main result is that women with this common luminal A subtype get no benefit from chemotherapy, even if node positive, even in the absence of hormonal therapy. And I'd just like to thank actually the women from Denmark who many decades ago were part of this study, because here we are decades later, and they're still informing us today on how to make the best decisions for managing breast cancer. Thank you.
Thanks, Dr. Nielsen. Interesting, the study started in 1977. The first year the symposium in San Antonio started as well. So just to summarize, we have data now on 633 premenopausal high-risk breast cancer patients, and on the subgroup of patients that had a luminal A breast cancer, which tend to be your ER positive, PR positive, HER2 negative, kind of a little bit of a better prognosis breast cancers. Dr. Nielsen's data suggested that chemotherapy would not benefit that patient population.